R.A.T.S. This topic needs no further expansion. And the heading that I had chosen for today's discussion will be a little complex, difficult to understand, and usually omitted by the students. The importance of the inflammatory bowel disease is given in the enclosure. The format of questions, the subjects involved are all mentioned. There are two of them, namely the Crohn's disease and the ulcerative colitis. We shall see them one by one. First, an overall about the Crohn's disease. Look at these words of definition. An idiopathic, chronic, ulceroconstrictive, inflammatory bowel disease. Each word is important. Idiopathic, chronic, ulceroconstrictive, and inflammatory. The salient features of this disease are the lesions are sharply demarcated. They involve all the layers of the intestine, have a granulomatous histology, and can involve any part of the GIT from the mouth to the anus. Further, there can be systemic involvement as well. These are the salient features. And there are also other terminologies. The older question papers used to give terminal ileitis as a question, regional enteritis, and granulomatous colitis, all of which are none other than Crohn's disease. The extraintestinal lesions will include skin with an erythema nodosum or a pyoderma. Bone, such as femur, might show osteoporosis as well as pathological fractures. Ankylosing spondylitis, very common, associated with HLA and Crohn's disease, go hand in hand. And also the striated muscles. So any of these can be one of the extraintestinal manifestations. A genetic predisposition has been considered because it is common in monozygotic twins. And the usual complications externally can be uveitis, arthritis, erythema nodosum, and a lower degree of cancer formation. Epidemiology. Some of the headings are for completion only. More common in the US and Europe, and it will be 2 to 5 times more common than the rest of the world. And it is less common in Japan. Age, there are two peaks, 20 years as well as the elderly. And females are generally more prone than males. Please remember this as a dictum. Any of the immunological diseases, autoimmune diseases, females are more prone than males. Who is this particular gentleman? Crohn. He was an American gastroenterologist after whom the disease has been named. Etiology and pathogenesis, nothing is proven, but then we have to write all. A history of infectious agents, we shall be seeing the list. Immunological mechanism, sometimes associated with psychosomatic disorders, as well as miscellaneous etiological factors such as dietary, vascular diseases, etc., have been implicated in the etiology of Crohn's disease. When I say infections, viruses such as rotavirus or Epstein-Barr virus, cytopathic virus, ECO27 have all been suggested, but there is no evidence of a viral etiology. Similarly, bacteria such as Mycobacteria cancer has been suggested, but no organism has been isolated from the lesion. So they remain hypothetical. An immunological etiology has stood the test of time because people consider it to be antibody mediated, cell mediated, or even associated with immunodeficiency. So, an immunological factor is definitely of importance, and the antibody usually along with this IgG. A very nice fundamental diagram regarding Crohn's and ulcerative colitis. Look at the differences. As mentioned, you find that Crohn's can be found as skip lesions. They can be either in the small intestine or the large intestine, and there is an intervening normal unaffected area. As mentioned earlier, it can be anywhere from the mouth up to the anal canal. Skip lesions will be the classical hallmark of Crohn's. Whereas in ulcerative colitis, it begins in the colon, goes backwards, and it is a contiguous or a continuous lesion. Sometimes it can go up to the cecum and even enter the ileum, in which case it is called as backwash ileitis. These diagrams you people can draw for both. What are the morphological features of the Crohn's disease? Look at this particular picture before I go into the text. I find that there is a segment of the intestine which has got a narrowed lumen, and then there are some linear ulcers which are called as serpentine ulcers. There will be the tags of fat which tend to creep over and they cover almost the entire circumference of the colon. So what are the lesions? There is a sharp demarcation as we had seen in the previous diagram. Skip lesion similarly. Normal, abnormal, and again normal. Terminal ileitis. So the terminal part of the ileum can be involved. It is edematous, rubbery in consistency. The entire intestine in the initial stages will be rubbery in consistency. Later on they develop a hose pipe like. A hose pipe is a rigid pipe used for commuting water for a long distance. So it will be quite firm in consistency. And creeping fat, as I had mentioned, the fat creeps over and covers the entire circumference of the intestine. String sign is more of a radiological sign. As I told you, there will be a narrowing of the lumen, and when you take a contrast X-ray, there will be a small string of contrast material that can be seen, which is called the string sign. The ulcers, please remember this particular picture, serpentine in nature, serpentine ulcers. The morphology continues, and this is the source of it. I find abnormal area as well as normal area. In the abnormal area, the mucosa is edematous, and we call this as a pebble-like or cobblestone-like appearance. There are narrow fissures in between the edematous mucosal pebbles. Serpentine ulcers, as we had mentioned in the previous slide, can be seen. Then the inflammation can penetrate the entire thickness of the intestine. Sometimes it leads to fistulae, perforation, or abscess formation. Histologically, you find that there is a transmural chronic inflammation. It is a chronic inflammatory lesion. Transmural means it involves the entire thickness. I am showing only the mucosa and the submucosa, but it will involve even the muscular and the serosal layers. And the inflammatory infiltrate will be in the form of lymphocytes and macrophages. One of the classical lesions will be the granuloma. Granuloma is an accumulation of the macrophages or the epithelioid cells. There is no caseation. Hence, it is called a non-caseating granuloma. Lymphatic dilatation or sclerosis of the blood vessels can be seen. Fibrosis, as I mentioned earlier, initially the intestine is soft, but later it becomes fibrosed, hose pipe, like in rigidity. There can be aggregates of inflammatory cells, such as the lymphocytes. Please remember this. and draw this diagram. What are the complications of a Crohn's disease? There can be a blood loss in stools, perforation, obstruction, fistulae, or even abscess formation. Cancer of the small intestine or the colon. Malabsorption is classical because many elements cannot be absorbed, so it leads to an imbalance in the diet. Extraintestinal, we had seen uveitis, ankylosing spondylitis, sclerosing cholangitis, and pyoderma. So these are all the complications. This is a superb diagram. The author is over here, and I had the courtesy to acknowledge her. The Crohn's disease and the ulcerative colitis. So I find that there will be skip lesions. There can be normal lesions and unaffected areas. Transmural inflammation, it involves the entire thickness. So there can be fistula formation. Sometimes there can be perforation with abscess formation. Whereas in the case of an ulcerative colitis, it is more continuous. It is more continuous. In this case, this is a lesion, this is a normal mucosa, the lesion, and then the normal mucosa. Here it is continuous. And it is not transmural, it is superficial. There can be the mucosal tags called the pseudopolyps. This is a very nice rough sketch for us to register. What are all the differences? A tabular column is always required. Classification is an aid to orderly thinking. And think of the subheadings. The subheadings will take you to the answer. Site of origin. Usually ulcerative colitis, it is a rectum. Crohn's disease, it can be the terminal ileum. Patterns, continuous, here it is skip. Thickness, mucosal or submucosal, transmural. Lesions, you can see pseudopolyps in ulcerative colitis, cobblestone appearance that can be seen. Granuloma is again classical in a case of Crohn's disease. The radiological findings in ulcerative colitis are unremarkable, whereas we see a string sign due to the narrowing of the lumen in Crohn's. Complications in ulcerative colitis include toxic megacolon and malignancy 3 to 4 times more common than usual. Crohn's show fistulae as well as lesser incidence of malignancy. The histological hallmarks are crypt abscess in ulcerative colitis and granuloma in Crohn's disease. Please study this mnemonic, and this is the source. Christmas, cobblestone, high temperature, reduced lumen, intestinal fistulae, skip lesions, transmural inflammation, malabsorption, anemia, and submucosal fibrosis. So this is Christmas. I would like you people to definitely memorize it. Next is ulcerative colitis. It is a recurrent, acute on chronic ulcero-inflammatory disorder of unknown etiology. The highlights include the common sites are rectum and the left colon, but it can go up to the ileocecal junction. It is a contiguous lesion. There are no skip lesions in this. Crypt abscess is classical. As mentioned earlier, the inflammatory bowel diseases are associated with other disorders such as migratory polyarthritis, ankylosing spondylitis, uveitis, and HLA-B27, human leukocyte antigen. Epidemiology, worldwide in distribution, more common in Britain and North America, less common in Asia and Russia. Whites are more prone than blacks, and females, as mentioned earlier, are more prone than males. The incidence is given here, and we find that with increase of age, there is a greater incidence of ulcerative colitis. What are the morphological features? Begins in the rectum and spreads in a retrograde contiguous manner. There are no skip lesions. Superficial ulcers can be seen. Also, there are some lesions called as the pseudopolyps. These are remnant tags of the mucosa which are left behind and not true polyps. Tunneling of the mucosa. There will be superficial ulcers and then submucosal spread, which leads to what is called as tunneling with overlying mucosal bridges. Toxic megacolon or dilatation due to the weakness of the colonic wall. Backwash ileitis, as we had mentioned earlier. From the colon, it goes into the ileum. And alternating ulcerative as well as healing processes can produce patchy appearances. This gives a false picture of a skip lesion. So the important things will be the types of ulcers and the healing as well as the pseudopolyps. This diagram we had seen earlier in ulcerative colitis, it begins in the rectosigmoid region and it can spread in continuity, go up to the cecum and sometimes into the ileum also, in which case it is called backwash ileitis. And here I am finding multiple pebble-like structures. These are actually the remnant mucosal tags which are left behind after ulceration. And these are pseudopolyps and not true polyps. This is a beautiful diagram. I would like you people to kindly rehearse and draw. A normal colon composed of tall columnar cells and the pale goblet cells. And in the case of ulcerative colitis, this is a crypt. Crypt means it is just a crack or a crevice in which I find that there are aggregates of neutrophils. And they can also be seen in the pericryptal area. And this is called as a crypt abscess and this is cryptitis. Microscopic continued. There will be hyperemia or congestion, edema that can be seen. Crypt abscess, that is what we are seeing here. Within the crypt, I am finding neutrophilic aggregates. They are spreading through the epithelial wall. And acute to chronic inflammation. Sometimes it is acute, but later on it can be superimposed with a chronic inflammation. What are the complications of ulcerative colitis? Colonic cancer, definitely. This is 3 to 4 times more common in ulcerative colitis than in Crohn's disease. Toxic megacolon, because of the weakness and the distension. In fact, this itself is a picture of a toxic megacolon. I find that the colon becomes thinned out and distended. Bloody diarrhea and electrolyte imbalance. In fact, this can be a cause of death in a case of Crohn's disease, ulcerative colitis, as well as Crohn's, because there can be the loss of the sodium and the potassium leading to fatality. A mnemonic that I had picked up from this source, I would like you to kindly rehearse it. Pain in abdomen with fever. Mnemonic. Pain. P for pain, P for pseudopolyps, A for anemia, I for inflammatory bowel disease, N for neutrophilic infiltration. Pain. In. Increased bowel sounds. No appetite or loss of appetite. Abdomen. A for abscess, B for bloody stools, D for diarrhea, O for onset of ulcers, M for malnutrition, E for extensive colitis. N, it is not sudden, it is a gradual disease. And weight loss, fever and fatigue. That is supposed to be W and F. Weight loss and fever and fatigue. Pain and abdomen, all the letters are included. Here the first letters of these two with fever. Weight loss and fever. So dear students, both are important university questions and a number of MCQs and viva voce questions can be asked. I hope you benefit from this. ZZ.